Hello and good morning, everyone. Welcome to the week 7 clinical contact session. The topic for this week was opportunistic infections, CNS, and TB. If you remember, we had done a similar topic a few weeks back, which was non-CNS and non-TB opportunistic infections. So in this week, we will be, I'm sure you might have seen these two lectures by UW faculties, that is CNS OIs in HIV and tuberculosis. So this session will be kind of a revision of those two lectures conducted by UW faculty. The two lectures have been uploaded on your on the UW website. So if you have not gone through those two lectures, I will request you to please go through those two lectures before you attend quiz for this week. So what I am going to do here today is we'll try to finish this clinical contact session by 12:30 or 12:15 or 12:30. So let's see how it goes, because I'm sure that on TB you might have attended many lectures recently after rollout of daily anti-TB treatment. But CNS OIs is one area where recently there has not been any, even in NDLS there were not many sessions on this topic. So what I've done is I've taken slides from NACO MO curriculum so that it will guide us to discuss the relevant areas in our clinical scenario. But it will be really important for you to go through these two lectures by UW faculties before you attend the quiz. So let's see what we can gain from these two sessions. So I've combined slides from the CNS OIs and also TB HIV. As I said, TB HIV recently there have been many trainings and seminars and webinars on this topic. So we can go fast on it, but for CNS we'll go a bit slow so that we can finish by 12:15 to 12:30 most probably. Okay, so let's start with this. Now if you might have observed, and those people who are working in ART centers since long time now will agree with me that the prevalence of OIs in general have reduced over the years, especially those serious OIs, for example CNS opportunistic infections and other opportunistic infections. We have seen in late like 2000 and in the first decade of 2000. So those kinds of OIs we are not seeing that commonly. So that includes CNS opportunistic infection, for example cryptococcal meningitis, toxoplasmosis. The way we used to see these infections in 2007, 8, 9, we are not seeing these days. And it is very logical to explain this, because the cutoff of CD4 for ART initiation has increased over a period of last 10 years. So if that happens, and we had seen this in the previous OI sessions also, that if the CD4 count is very low, there will be a risk of serious opportunistic infection. So if you start ART at higher CD4 count, risk of OI will also reduce, and this applies to CNS opportunistic infections as well. So in general, if you see the CNS or neurological diseases in PLHIV, in about 10 to 20%, this will be as a manifested as a first manifestation or symptom in HIV. And if you see the data which is mentioned in this slide as well, that most of the times these infections are not diagnosed, and after autopsy is done, there will be 75 to 90% of the cases where the abnormalities will be demonstrated. Only 60% of the cases you will see the lifetime prevalence of clinically evident neurological problems. Most of it is also related to investigation facilities available in our setups and also in our hospitals, and also strong clinical suspicion to diagnose opportunistic infections and treat. Sometimes patients do not report also in time at until very late stage of OIs, so that also will become a problem. Um, as you know that HIV is one of the reservoir sites. If you remember, we had talked about reservoir sites of HIV infection when HIV comes into the body. So brain tissues are one of the reservoir sites for HIV. So it does not affect only brain, but also it will affect the other uh, nervous system areas like spinal cord and peripheral nerves also. So if you want to divide the overall involvement of central nervous system, so patient may present with meningeal signs and symptoms, which obviously will be termed as meningitis or meningeal involvement or meningism, signs of meningism. There are two broad categories in which we divide this presentation. One is focal parenchymal symptoms or non-focal parenchymal symptoms and signs. What does it mean is focal is like localized to a specific area. That means you might see some kind of hemiparesis or monoparesis or even or hemiplegia. So there will be some lesion in the brain in a specific in a particular area, and because of that there will be certain signs and symptoms. Non-focal is usually generalized, where there will be signs will be like general disorientation, headache, vomiting, and all that, and there are some typical signs of meningism also. So broadly, if you want to divide or if you want to see the approach to the diagnosis of central nervous system involvement, these three areas are generally or it is generally divided into these three approaches. We can understand this better by with the help of a couple of cases we will see. Usually we in this whole series we did not discuss cases from NACO slides, but for the CNS I have tried to include this because it will be helpful to understand the clinical conditions better. So this is a 32 years old HIV positive male. CD4 is very low. As you can see, it is less than 50 in fact. Presented with headache, fever, fatigue of subacute onset. Now, all these symptoms are important to guide us towards the diagnosis. So this patient, like any other patient of similar symptomatology, was treated with paracetamol and antibiotics because he had fever and he had headache. Uh, so patient returns back after few days with some more lethargy and temperature is increasing, worsening of headache and molluscum like lesion. You might have seen molluscum contagiosum lesions. Those are vesicular kind of lesions with central umbilication, or it's very typical lesion. So one of the differential diagnosis for that also will be helpful to diagnose this kind of cases. So molluscum contagiosum, if you see on face or any other body area, and along with these signs and symptoms, worsening of headache and fever, then it should alarm that there will be some kind of neurological involvement or some kind of meningitis which is happening here. So examination, it revealed that nervous system also did not reveal any focal lesions. So this word will repeat in this presentation, that is focal and non-focal. Like I said before, focal will be termed as specified to a particular area and non-focal is generalized. So if you see here, there is no hemiplegia, no hemiparesis, or no any specific nerve involvement which has happened, or cranial nerve involvement lesions signs you can see here in this scenario. These are general sign of headache, fever, and fatigue. If you can see here, this is a kind of lesion, molluscum like lesions, and patient, if you can see here, is oxygen support and all will indicate that patient is having serious signs and symptoms and he's hospitalized. So history will be important, physical examination will be important in such kinds of patients. So whenever you see any neurological involvement or if you suspect any neurological involvement, you should ask yourself these three questions: that is there first, is there a neurological lesion which is in any part of nervous system? Then if it is there, then where is the lesion? And if you can figure it out, then what could be the lesion or what is the lesion? These days, CT and MRI will make our job very easy as far as where is the lesion is concerned. But to decide, because CT and MRI will not also be available freely with each and every one, so we'll have to take that decision whether a person should be sent for CT or MRI, or we should do lumbar puncture first, or we should do anything else before we do all these things. So, to take that decision, we need to clinically examine the patient and we need to uh, come up with some differential diagnosis so that our line of investigation and line of treatment will be decided. So, where is the lesion? This question is easy to answer as far as these days when we have all those facilities usually available, and this will be based on our clinical examination, and what is the lesion is completely dependent on the type of presentation most of the times, because most of the times you will not be able to identify the organism, especially if it is like intracranial uh, um, lesions, or some mass if you see, or um, any lesion which is very visible in the gray matter of brain. So that kind of lesion, it will be difficult to identify the organism which is causing it, but based on the presentation we usually make the clinical diagnosis and treat. So we'll see one of the examples of that as well. So back to our case, in this case the opening pressure. Now this is important. Opening pressure is those who have not seen many of the meningitis in HIV. So when you put in the the needles, the CSF needle in the to withdraw the CSF, so the pressure with which the CSF comes out is called as the opening pressure. So it is measured in terms in the measurement of millimeter of water. So in this case, CSF opening pressure is high; it is 350, and WBC also it is raised to 1 to 2 cells per cubic millimeter. Usually it is 0 to in that range, 0 to 1. So and even proteins have raised. Glucose and VDRL is negative. Blood glucose is 124. That is more or less normal. When brain CT is normal. So in this case, brain CT was already done and it was normal. So do we suspect meningitis in this patient? Yes. And what can be our differential diagnosis? Now it can be meningitis if we are suspecting. The differential diagnosis can be many, which will include bacterial infection, fungal infections, and other kinds of all other kinds of infection. But if you see this very low CD4 count and high opening pressure, and along with this all these signs, then it will go more in favor of cryptococcal meningitis. Of course, we will not make clinical diagnosis here in this case. There will be a test available for confirmation of cryptococcal meningitis, so those need to be advised. So top of our list of differential diagnosis will be cryptomeningitis, because we have seen the opening pressure which is very high and the way patient has presented with clinical signs and symptoms. Remember one more thing here is there is no neck stiffness in this case. So even though cryptococcal meningitis, the again as compared to bacterial meningitis, in this situations you will uh, uh, usually you will not see that commonly neck stiffness in such cases. of cryptococcal meningitis, though it is not impossible. So you will also see a cryptococcal meningitis along with patient presenting with neck stiffness and projectile vomiting and all other signs of meningism. So, but commonly, if you see here, it will be headache, which will be very throbbing headache. A patient will be having disorientation. Patient will be having a slow onset and low grade fever, and sometimes fever also can be high grade. So, but CSF pressure will again guide us. That is first sign for us, and also the definitive diagnosis can be with the help of lab diagnosis like cryptococcal antigen we can do, and also cryptococcal India ink preparation we can do on the sample of CSF. And bacterial meningitis, strep pneumonia, H influenza, and it can be anything. So tubercular meningitis and other chronic meningitis like fungal infections, viral meningoencephalitis like HSV, enteroviruses, and herpes, etc. So DD list of differential diagnosis can be really long in such cases if you want to see the DD of meningitis. But as I said, now CD4 is guiding us. That is, it is very low. Number one. Number two is CSF pressure is high, and number three, now you are also seeing the lesions on the skin. That is. Lesions like molluscum contagiosum, which is called as um, cryptococcal lesion or cutaneous cryptococcosis. So this is not molluscum contagiosum, but it is cutaneous cryptococcosis. So in this case, skin scrapings were sent for investigation, and there they diagnosed, because this is the case in which was seen in Government Hospital of Thoracic Medicine, Tambram, Chennai. So here, from the skin lesions, cryptococcus was demonstrated. So that is another indication that this might be most probably cryptococcal meningitis. But of course, the confirmation will be done in the lab, where the easiest. This is one of the very easy investigations. India ink preparation. India ink is nothing but the ink which we used to write, which earlier actually we used to write. Some people still use it. So the same ink. So it is very easy to see organism in this, where you can see a narrow base and capsule of the organism. If you are interested, you can visit lab to see this. It is very easy to do this investigation, and it can be done anywhere. Challenge will be only to withdraw the sample of CSF, where there should be some experience and some practice is required. And also it is important to for us to be familiar with, and also to be thorough with in our clinical practice, to do lumbar puncture, because that is one of the treatments also for cryptococcal meningitis. Because in crypto meningitis, as we have seen, that there is a high opening pressure, because of which there will be a free flow of CSF once you put the needle in the space. And if you are confirmed that this is cryptococcal meningitis after doing these investigations, then you can do therapeutic lumbar puncture also. Now there is a caution here: if you are not sure that this is cryptococcal meningitis, you should not be doing therapeutic lumbar puncture. Because we should understand the mechanism how the intracranial pressure increases in cryptococcal meningitis. So if you see bacterial meningitis, and if you see any other lesion in the central nervous system, because of which usually in bacterial meningitis it doesn't happen, but if suppose there is any space occupying lesion, there can be increase in intracranial tension. So in those cases, if you suppose withdraw CSF in large quantity, there can be problems. There can be herniation of the brain, and all those things can happen. So you should not be doing that. You should not be attempting it. So, but if you are sure that this is cryptococcal meningitis, by lab you did all each and everything, and now you are sure that this is cryptococcal meningitis, then you can remove CSF as much as 30 ml per day. Some of you will be surprised to know that usually we take CSF like 2 to 3 ml per day. for investigation, diagnostic lumbar puncture. But if you want to do therapeutic lumbar puncture, as much as 30 ml per day of CSF can be removed if you are sure that this is cryptococcal meningitis. Because in this, the pathophysiology is there will be a blockage of, because of the lesions of this cryptococcus, there will be a blockage of CSF flow, and CSF will not flow, and the CSF which is formed will again get accumulated, and because of which intracranial pressure will increase, the opening pressure will increase. So by by taking out or by doing therapeutic lumbar puncture, in fact you are reducing the burden of cryptococcus in the in the in meningeal space. So therapeutic lumbar puncture is one of the best interventions, but I will, as I said, these days we are not seeing first of all cryptomeningitis that commonly, and even if you see, we just refer patient from ART centers to medicine department, or in case in most of these scenarios it will be reverse, like patients will get admitted to the hospital and will be treated for all these things, and then will be referred to the ART center just for ART initiation. So as a clinician, you should not be satisfied with this kind of scenarios. So you should get yourself involved in management of such cases in your hospitals, and if possible, then I would suggest that try doing lumbar puncture and don't lose that clinical touch. So therapeutic lumbar puncture is something which you can do every day. So once a person is diagnosed, confirmed, and it will also help you to practice lumbar puncture in these patients. And it is actually not for our practice, but for the benefit of the patient. As I said, the organism load or will reduce a lot if you do therapeutic lumbar puncture. But that is not the only treatment. It is in combination with the usual antifungal treatment for cryptococcal meningitis, which is with amphotericin B. Now, amphotericin B is very important. Sometimes when, if suppose this is not available, people give high dose of fluconazole like 800 milligrams per day for a long time, but it is not advisable. There is a very high chance of relapses in cryptococcal meningitis. So relapse, if you want to avoid relapses, a patient should sufficiently receive for 2 to 3 weeks. In my opinion, it should be 3 weeks of injection amphotericin B, 0.7 to 1 milligram per kg once a day. It is given as an IV infusion. And it is followed by, now treatment does not end here. Sometimes what happens, we give intravenous injection amphotericin, but people do not, or patient do not continue on fluconazole, or if fluconazole is given, it is in the dose of 150 milligram, because that is most commonly available tablets, and 400 milligram is not given. Please remember that until unless patient takes treatment for 8 to 10 weeks, treatment of cryptococcal meningitis is not over. This is a part of same treatment. Initial 3 weeks injectable antifungal and amphotericin B. After that 8 to 10 weeks is oral antifungal, that is fluconazole. This is called as maintenance phase, and this is induction phase. And after that comes a secondary prophylaxis. This is also very important if you want to avoid relapses, because relapses are very common. Fluconazole 200 milligrams once a day orally till the CD4 count raises to more than 200 or 350 in our recent guidelines after ART initiation, and it should be sustained at least for 6 months. So in cases like this, I would also advise that, because see, sometimes scenario can be very mixed, especially when the relapse happens. Recently I observed a case where there was a case of cryptococcal meningitis treated with injection amphotericin B. Patient took tablet fluconazole for almost 6 to 8 weeks, and then after few months of antiretroviral treatment, again patient developed meningitis. So what they did, they tried to again do the CSF analysis in that patient. Proteins were high, glucose was again more or less normal or less than normal, and there were few cells which were seen, and along with that, cryptococcal antigen was positive. Now, um, before this, we saw only India ink preparation, where you will see Cryptococcus neoformans as an organism. But cryptococcal antigen positivity, that means it is a fraction of it is antigen of Cryptococcus neoformans. So, if you see that in the relapse, that does not mean that relapse of, or if you see that in the second episode, in the example which I am giving you now, in the second episode of meningitis, if they see that this is cryptococcal antigen positive, now it is very much possible that this antigen positivity can be because of the previously treated cryptococcal meningitis. Are you with me on this? That you treated cryptococcal meningitis with an amphotericin B, and now you are seeing only antigen positivity, but not India ink positivity. What does it mean is that it may be relapse. We are not sure. Number one. Number two, it can be any other form of meningitis also. It can be TB meningitis. Why it should not be? Now, the CSF presentation is similar to TB meningitis. Only thing is we have here as CSF cryptococcal antigen positive. So to differentiate such cases, there is another investigation which is helpful, which is called as culture. So CSF culture for cryptococcal antigen can, or Cryptococcus neoformans can be done. It is very helpful. So if suppose culture is positive, then you will have to treat this second episode again with injection amphotericin B. But if culture is negative, then it means that it is not a relapse of Cryptococcus. Might be it can be TB meningitis. So you need to give TB treatment also in such cases. So relapse situations are common with Cryptococcus, especially when you don't treat them with injection amphotericin B. So we should make sure that all efforts are taken to arrange for injection amphotericin, and such cases should receive injection amphotericin B. And number two is they should complete the maintenance phase of 8 to 10 weeks. And number three is secondary prophylaxis of tablet fluconazole 200 milligram. They should receive until unless CD4 is much beyond the risk cutoff. Now, and that is the reason, if you remember TB, there we say that TB treatment should be initiated as soon as possible when a patient is diagnosed with HIV-TB co-infection. But unlike TB, in cryptococcal meningitis, we delay initiation of antiretroviral treatment. If you see the second bullet, ART initiation should be delayed for 2 to 6 weeks in these patients if they were treated only with fluconazole, that is non-standard therapy. Because as I mentioned you before, some people they do not arrange for this, and they if amphotericin B is not available, they give only high dose fluconazole. So in such cases, especially ART should be delayed. Otherwise, also I think in case you have patients of cryptomeningitis, at least delay it for 2 to 3 weeks or 2 to 6 weeks in case if it is if injection amphotericin B is not given. Culture report comes in how many days? Usually culture report comes in 10 to 12 days if I'm not wrong, but you can check with your lab. Some of the or most of the labs I don't think they do it because of the reason that this is not very commonly advised test. But as I said, it may not be required in the first episode, but in the second episode where you have this confusing scenario of antigen positivity, and also you have treated with full dose of amphotericin B sometime back, where you are not sure, then and then I think fungal culture will help. But of course, you will require a good lab support for this. This is comparison between other kinds of meningitis like pneumococcosis, where you will see high neutrophil count and protein is very high and very low sugar. So this is bacterial meningitis where gram stain and routine culture will be positive. Cryptococcus again, lymphocyte may be normal, protein may be elevated, sugar will be a little bit low, not very low. India ink preparation will be positive. An antigen test or culture can be done. This is what I was talking about. Then TB lymphocyte count will be again very high in TB. Proteins will be very much elevated and low to normal sugar. And sometimes Mycobacterium tuberculosis culture will give positivity, but usually it may come negative very commonly. Syphilis, again, there can be lymphocyte can be mildly elevated, protein little high, sugar can be near normal, but VDRL can be positive, or uh, Treponema pallidum antigen test (TPA) can be also be done in these cases. If patient is on injection amphotericin B, then wait for 2 to 6 weeks or start as early as possible. I would suggest that still in that case you should be delaying initiation of antiretroviral therapy for at least 3 weeks until your injection amphotericin B is complete. Again, for the same reason of relapse. So, unlike TB, in cryptomeningitis, the initiation of ART is delayed. That is my opinion on that. Okay, just let's move on to next case, HIV positive male. Now, the first case, if you see the earlier sort of classification I told you regarding approach, it was a presentation of non-focal or global cerebral syndrome. It is also called as global cerebral syndrome. That is non-focal presentation. Now, in this case, we will be focusing on focal neurological deficit or specific area which is involved of brain. So this is HIV positive male, 32 years, was hospitalized for focal convulsions. Please remember that word. And systemic examination revealed upper limb weakness, that is monoparesis with other abnormalities. If you remember the my opening remarks for this presentation, in which I mentioned that there will be one specific area of the brain which is involved, that is called a focal lesion, and it is accompanied by what symptoms? Right? Patient had convulsions here, so that those are more common with focal lesions, and then monoparesis or weakness of specific one upper limb, for example, that is called as focal neurological deficit. So you can remember two broad terminologies, that is global cerebral syndrome, where with the presentation will be like meningitis or signs of meningism, or like um, the other generalized cerebral infections like HIV encephalopathy and all that. And then you have the other term as focal neurological deficit, where there will be lesion in the brain at some area, and it will call focal deficit of the area which is affected because of that lesion. So in this scenario, you'll not do lumbar puncture first, because if you see any focal deficit, then there is possibility of raised intracranial tension because of space occupying lesion, where I said that if you do lumbar puncture, there is a risk of herniation of brain, so through foramen magnum. So that should not, that will be risky. So whenever you see convulsion or focal deficit, or you see any monoparasis or monoplegia, paraplegia, then do not attempt lumbar puncture before you do CT scan or MRI in such patients. Here you can see ring enhancing lesion. You can see enhancement after giving dye. So there are multiple lesions which are seen here in cerebrum. So the important differential diagnosis for enhancing hemispheric lesions after focal neurological deficit can be toxoplasmosis, tuberculoma, neurocysticercosis. Now this is again one thing which we should remember in HIV. Then brain abscess or bacterial infections or fungal infections or because of fungal infections, and then lymphoma, especially primary CNS lymphoma, that we should remember. So clinical features will be encephalitis sometimes, and then fever and headache, seizures, that is convulsions, mental status change or focal neurological signs, that is hemiparesis in this case. Now MRI or CT show that we can do brain biopsy, but I don't think it is required. Usually how the definitive diagnosis is made lesions, and someone mentioned also that it can be because of toxoplasmosis. So other DDs also we saw that it can be because of TB and primary CNS lymphoma. It can be because of cerebral cysticercosis and others. So in this case, as usually see brain abscess and primary CNS lymphoma, this will be one big lesion. Usually, the usual presentation will be like that. But in toxoplasmosis, it will be usually multiple lesions. But again, it is not very definite. But in presence of suppose serology positive for toxoplasma, you can decide on treatment for toxoplasmosis, which is nothing but which is again called as a presumptive treatment, because we are not doing brain biopsy in these cases. So treatment for toxoplasma can be with sulfadiazine 4 to 8 gram per day in 4 divided doses. Usually if that is not available, then sulfamethoxazole is used, which is not the definite treatment, but availability of sulfadiazine is at most of the places it is not easily available. I think I am able to see the slides now. So yeah. So there can be alternative along with sulfadiazine. Uh, we use pyrimethamine in the dose of 100 to 200 milligram per day for 6 weeks, and then 50 to 75 milligrams. Alternative for that is in case of sulfur allergy and all that, then we use clindamycin or macrolide like azithromycin, clarithromycin. The best option is high dose cotrimoxazole, but other options are less efficacious. Like cryptomeningitis, even in toxoplasma we have maintenance phase. This is again a long maintenance phase. Pyrimethamine half of the dose of earlier, and sulfadiazine again half of the dose. All patients require prolonged suppressive therapy, especially for maybe for 3 to 6 months, or at least until CD4 goes above 200. 86% of the patients show clinical improvement by the 7th day, and this is very drastic. If you have treated or managed patients with cryptomeningitis, you will agree with me that the clinical improvement will be very fast in these cases, and in 95% of the cases it will be radiological improvement within 14 days. That is very satisfactory if you are treating such patients as a clinician. So that need to be monitored, that need to be closely monitored in fact. And when you don't get such a response, then you need to revise your diagnosis. Failure to respond within 14 days, then you need to consider the alternate diagnosis, and that is the indication of brain biopsy, which may not be available at most of the scenarios. Tuberculoma are usually solitary, or it can be multiple lesions also, but usually solitary. And 1 centimeter size nodular ring enhancing lesions with and without associated mass effect or edema. And in contrast, tuberculous abscess is large solitary lesion with central area of liquefaction. They appear hyperintense on T2 weighted MRI images and generally associated with mass effect. That is difference between tuberculoma and TB abscess. What mass effect is, in that you will see there is from the midline there will be deviation, that is called as mass effect. And then in hydrocephalus, basilar meningitis or cerebral infarction develop at least 1/3 of the patient of CNS tuberculosis. Especially if you see TB meningitis, if you have treated such patients of TB meningitis, you give steroids in these patients. Why we do give steroids? Because For serous membrane tuberculosis, we give steroids to avoid the fibrosis. What happens if fibrosis takes place in these scenarios? There will be blockage of CSF circulation, which causes increase in intracranial pressure, which is ultimately results in hydrocephalus. So that is one of the TB sequelae. It is called as TB sequelae, that is post TB sequelae. You treat tuberculosis, patient will be cured of TB disease, but if TB heals with fibrosis, that will cause blockage of CSF circulation. It will result in hydrocephalus, and sometimes it will require HP shunts also. These are this happens in TB, and if you can see the lesions of TB here in the again brainstem or in this area also you can see TB lesions. So as algorithm, if you see a patient walks in with headache, then and it is persistent in it is a PL-HIV, there is evidence of immune deficiency, that is previous OI, thrush, weight loss. Then like I said, we need to divide this into two categories: fever with signs of meningism and focal seizures or signs, that is signs of focal neurological deficit along with seizures. If there are seizures and signs of focal neurological deficit, then we will do CT scan or MRI first. If it is normal, then we can go ahead with CSF lumbar puncture. If it is showing ring enhancing lesions, then treat for toxoplasma, lumbar puncture and CSF analysis can be done after that. If there are signs of meningism, then do CSF analysis first and rule out the other infections before you go for radiological imaging. So this is an easy algorithm, and the more or less summarizes what we have discussed up till now. Let's move on to another case before we close this CNS manifestations. 46 years old female, PL-HIV with CD4 44, not on ERT, very low CD4, not on ERT, presents with incoordination of her right hand and unsteady gait and slurred speech. Now these are the again symptoms that is which are again directing us towards the fine motor loss or functional loss. This thin-built woman with alert and well-oriented was alert and well-oriented earlier. BP is low or on the lower side. Heart rate is 90 and other things are okay. She was a slight right facial droop, right hand weakness and dysmetria and unsteady gait due to mild right leg weakness. Now, if you see all this presentation, this is obviously not a global syndrome. We are seeing some kind of focal lesions also here. So we go for MRI first, and MRI or CT you can do. So these are MRI T2 weighted images where you can see this leuco or white matter, that is so these lesions are more in favor of focal progressive multifocal leukoencephalopathy. As name suggests, it is progressive. It slowly increases. Multifocal, more than one sides are involved. Leuco is white. Encephalopathy is involvement of brain. So it is called as PML. It is caused by JC virus. JC is behind the name of the patient in which the first time this virus was seen, and rapidly progressive if not treated. There is no specific treatment for this kind of disease. It is usually cognitive dysfunction, ataxia, aphasia, cranial nerve involvement, hemiparesis or quadriparesis, and eventually coma. So, and typically presents with focal CNS signs, and that is why we did MRI first. Preference for occupied occipital lobe, that is which causes hemianopia, that is half vision loss. Then frontal and parietal lobes, which causes hemiparesis, and cerebellum ataxia or dysmetria. Seizures can also be present in some cases. So, as rightly said by Dr. Nazia, so there is no specific treatment for this. Usually, if you start ART, there will be arrest of progression, and patient may get better also. So, CT abnormalities include single or multiple hypodense, non-enhancing or poorly enhancing cerebral white matter lesions, MRI will show patchy white matter lesions, and in 10 to 15% enhancement with um, gadolinium. So JC virus, again DNA, it can be detected by PCR of CSF specimen, but sensitivity is, again, it ranges between 42 to 100%. So, and specificity is high. So that means if it is positive, then it is more favor of definite diagnosis of JC virus. And it is available also, though it is not indicated. Not indicated in um, it is not very commonly available, but it is available. So, but available in private. So, because of relatively high positive predictive value of the test, a patient with positive PCR result who has a compatible radiological picture can be assumed to be having PML. That is again just to ensure our diagnosis, but the treatment doesn't change. Negative test does not rule out PML. So ART, more than 60% response, and 20 to 30% they improve. Poor outcome for those who have CD4 very low, that is less than 150. Steroids can be helpful in PML iris, so there can be PML iris also. So that summarizes our CNS manifestation. It is again very quick, very common presentation of CNS. If you go in details, there can be many again issues or which can be discussed under CNS manifestations. So as far as HIV TB, as I said, there were multiple discussions and multiple presentations which happened for HIV TB. You might have recently seen. So I'll just quickly go through these slide sets so that it can be a revision for all of us. We know that TB accelerates HIV disease, and also AIDS, it paves way for clinical presentation of tuberculosis. So it is generally a cycle, the way these two interact. Because of AIDS, there will be worsening of immunosuppression. That is, there will be immunosuppression which is happening in later stage of HIV infection, which causes decreased interferon and other lymphocytes. And then Mycobacterium tuberculosis will present as a clinical disease if it is already there as an infection. And there will be macrophage production which will increase the replication of HIV virus and which will ultimately add up to the increased viral load. So this is a vicious cycle which will help both the diseases to flare up in a person who is already ill. So there is a term called as a latent tuberculosis, which is called as primary TB infection. The way TB infection happens is, it is most common route is through aerosol infection, and active disease usually happen in immunocompetent person in 10% of the people, and 90% of the times it remains as a latent infection. A latent infection is hidden infection, which means that there is no clinical signs and symptoms, but a person has TB bacilli in his or her body, and there is a 10% chance that in future this will get as a reactivation of tuberculosis, which might happen because whenever there are favorable conditions for TB organism. So usually it happens like this: at the day of infection, there will be a primary focus, and there will be involvement of the lymph nodes of hilar lymph nodes, and also there will be lymphatic involvement. And this complex, this is again primary area of involvement, and this complex is called as Gons complex, where you have hilar lymph node and primary lesion, and also lymphatics which are involved. What happens to this is usually there is it gets subsided by its own. But if suppose a person is immunosuppressed, or there are favorable condition for TB organism to multiply in such scenarios, there can be a form of progressive primary tuberculosis also. And when this happens, then it has to be treated. But usually Gons focus, it goes unnoticed. And what happens is there is something called as primary dissemination of TB bacilli. So if this Gons complex or Gons focus, it comes in contact with the lymphatics or the blood vessels, there will be hematogenous dissemination of this TB bacilli throughout the body. So if it enters the bloodstream from here, and it goes to all parts of the body, and it gets lodged in various areas. For example, apex of the lung is some of the common areas where it will get lodged. So, and what happens after that is the primary focus, it disappears and bacilli will be present here. Now this area will be again an area where the uh, perfusion will be low, but again oxygenation will be high, and that will again help in TB bacilla in future if bacillus gets favorable conditions to flare up, and that is called as reactivation of tuberculosis bacilli, where they will present as again TB disease. So there are two terminologies which we need to understand. One is endogenous reactivation. Endogenous reactivation means bacillus was already present and reactivation happened because of the favorable condition, that is reduced immune system of a person. Second term is called as exogenous reinfection. That means a person was already having low immunity and then new infection happened. People have tried to differentiate these two also with the help of DNA mapping, which we'll see in, after a couple of slides. So in which they saw that the new infection which was happened was different from the already happened infection in that person in the previous episode. So this is latent tuberculosis, where infection is present in a person's body, but there is no clinical signs. So as I mentioned, it is TB bacteria which live in the body without making a person sick. It is called as TB infection, and there are two things which we saw: exogenous reactivation and endogenous reinfection. Endogenous reactivation and exogenous reinfection. So latent tuberculosis is inactive. It contains tubercle bacilli in the body. Tuberculin skin test will be positive in both latent TB and active TB. In active TB, you will have multiple patients. You will see all signs and symptoms of tuberculosis usually. Chest X-ray is normal. Here it is abnormal. Sputums are negative. Here it is positive. No symptoms, no infectiousness. Not a case of TB. So most of us who work in hospital, if you genuinely have worked with TB patients and have visited wards frequently, you and I will be infected with TB bacillus. So we are infected. We might be having latent TB. But we do not have TB disease as such, because TB disease is different from TB infection, like HIV positive is different from having AIDS. So it is similar analogy you can use there. So in PPD positive, that is purified protein derivative, that is Montauk's positive, in simple terms if you say, there is 10% of lifetime risk of development of tuberculosis, but in HIV positive, this risk increases to almost 60%. That is, lifetime risk of TB increases. So that is why an estimated TB among PLHIV in India is estimated to be 5 to 6%. So in early phase of the disease, the presentation will be similar like any other immunocompetent person, but in late phase of the disease, it will be like a primary tuberculosis, because there will be often the mid-zone or lower zone infiltrations. There will not be any cavity formation. There will be disseminated kind of presentation, usually like miliary tuberculosis. There can be mediastinal widening or mediastinal lymph node or intrathoracic lymph node enlargement, which might happen. So those are late phase presentation, or in late phase of immunosuppression. But in early phase, when immunity is good, presentation is like any other immunocompetent person. Okay, I'll just read this. Taking away from this topic, a patient on ATT and ART regimen is raltegravir, lopinavir, and ritonavir. Any change in ART regimen, and he is on rifabutin instead rifampicin, kindly suggest. We'll come back to this question, but just to quickly answer this, rifabutin does not have any interaction with the PIs, so you need not change. So mycobacteremia and extrapulmonary tuberculosis, this is how it is seen. If CD4 count is very low, you will see more mycobacteremia, that is more of disseminated kind of tuberculosis. Extrapulmonary tuberculosis also, if CD4 count is again low, you will see more of extrapulmonary tuberculosis or disseminated unsuspected tuberculosis. We already discussed this, that there will be exogenous reinfection and endogenous reactivation. Diagnostic yield of conventional tests like LJ medium, that is Lowenstein Johnson agar. So usually conventional cultures, it will take a longer time, like 4 weeks to 6 weeks. So we cannot wait for that time. And nowadays there are many good tests which are coming up. We use CBNAT. This is what sputum microscopy yield is. HIV in HIV negative people, 60% of the people will be like sputum smear positive. And active pulmonary tuberculosis, early HIV 50%, and advanced HIV only there will be 30% positivity of sputum smear microscopy. On X-ray, if you see, this is X-ray with good immunity, where you will see upper zone infiltrations or cavity formation here. And as and when CD4 reduces, there will be like mediastinal lesions. You can see here mediastinal widening along with mediastinal lymph node, and you will see here also the pleural effusions. So this happens is late immune suppression, and this is when immunity is intact. Because to form a cavity, this is nothing but a sign of good immune system, good responding immune system. So, and relevance of X-ray, if you see from this study, is X-rays. 7% of the patients which had normal chest X-ray, but they were having culturally positive tuberculosis. So this means that you cannot just rely upon X-ray, because it has again subjective differences in X-ray reporting. So even if the X-ray is normal, but if you suspect tuberculosis, you should send a sample for CBNAT these days, if not for sputum smear microscopy, because normal X-ray does not rule out tuberculosis. That is what this slide says. There are different program definitions, that is microbiologically confirmed. That means, as name suggests, you are confirming TB bacillus in this through CBNAT. Clinically diagnosed, that means you are not confirming by seeing organism. You are relying upon some of the investigations like chest X-ray or USG abdomen or any other radiological investigation like CT scan. Pulmonary TB, as name suggests, it is TB of lung parenchyma or tracheobronchial tree. Extrapulmonary TB is any TB which is beyond the other than pulmonary TB is extrapulmonary. But for RNTCP convenience or reporting convenience, if a person has both pulmonary and extrapulmonary TB, it is reported as pulmonary TB in RNTCP records. So how it is diagnosed? Intensified TB case finding is happening in our centers these days. That is 4-symptom screening. Everyone is aware of these 4-symptom screening. So if it is pulmonary TB suspect, then CBNAT, sputum CBNAT is sent and chest X-ray is done. If sputum CBNAT is positive, it is labeled as microbiological confirmed tuberculosis. If it is negative and X-ray suggests TB, then it is confirmed as clinically diagnosed TB. And if sputum CBNAT is negative and X-ray is also normal, then it is considered as non-TB and we consider other diagnosis. For extrapulmonary TB, CBNAT is sent or culture is if positive from extrapulmonary site. Usually the sample which is sent for extrapulmonary for CBNAT from the extrapulmonary sample is any other tissue other than blood, feces and urine can be sent for CBNAT. Or if it is cyto or histopathological examination, for example, lymph node which shows granuloma, granulomatous lesions can be labeled as TB. In advanced, again, immunodeficiency, you will not see granuloma, but there will be multiple lymphocytes. X-ray chest and other radiological examinations, these can be done, and based on that, our diagnosis is made. And if it is suggestive of tuberculosis, it is labeled as extrapulmonary tuberculosis. As we said, these days we are using CBNAT more commonly than sputum smear microscopy because of the obvious reasons that through CBNAT the sensitivity is very high. You will be able to diagnose almost more than double cases as you would diagnose with sputum smear positivity. You can see here it is almost twofold increase, more than twofold increase in all the groups of populations and areas as compared to this routine smear microscopy, and that is why we are using CBNAT these days. CBNAT stands for cartridge based nucleic acid amplification test, commonly called as GeneXpert, but that is a misnomer because it is a brand name. but name of the test is CBNAT, so we should be saying it as a CBNAT. It is very sensitive and specific. It detects not only the organism but also it detects rifampicin resistance, which will help us to treat this patient with a first line or second line anti-TB drugs. It is easy to perform. There is a small machine and cartridge in which sample is placed and results are obtained quickly. Sensitivity is very high. The median sensitivity or smear sensitivity of smear microscopy, if it is 52%, of CBNAT it is 84%. So it is almost more than double of smear. As I said, it is all these samples can be sent from extrapulmonary sites for CBNAT. And there is a special tube in which a sample is collected. It is called as Falcon tubes. When you collect the sample, for example, especially biopsy samples, it should be sent in normal saline and not in any other preservative, because ultimately it will damage the TB bacillus and you will not get the appropriate results. So it should be in normal saline in Falcon tube and not in formalin or CPC. Iris tuberculosis, we have spoken about it. Once you start treatment, there can be clinical deterioration or worsening or appearance of new signs and symptoms. Like, for example, in this case, it is labeled as iris. So if a patient is already on treatment, TB treatment, you need not again add anything. You just need to, you can treat with steroids also in such cases. But if patient is not on TB treatment, if it is unmasking type of iris, then you will have to start anti-TB treatment. Drug resistant TB, this again these days problem is increasing day by day. If this is total TB cases without any drug resistant strain, then there will be some of them will be having resistance to one or another drug. If they are having resistance to at least NH and rifampicin, then such cases are called as MDR TB. And in addition to that, if these cases of MDR TB have also resistance to any of the injectable aminoglycoside and fluoroquinolone, then it is called as XDR, that is extremely drug resistant tuberculosis. Why drug resistance happens is usually it's a man-made problem. Naturally occurring drug resistance is very low to the extent of 10⁻⁵. Resistant TB bacilli which are naturally occurring. Otherwise, these are very sensitive to INH and rifampicin. But if a person, or if there is subtherapeutic drug levels which are in the blood, or if a person does not take anti-TB treatment regularly, then there will be a risk of drug resistance which is developed. So primary drug resistance is very low, acquired is very high. MDR suspects are referred for culture and drug sensitivity testing, and in under RNTCP for MDR there is a treatment category of category 4 and XDR is category 5. As I mentioned the definition, this is the same definition of MDR and XDR TB. Why we do 4 symptom screening? Every one of us is doing these days at our ART center. This is being done because of this negative predictive value, which is very high. What does it mean is, what are those 4 symptoms we see? That is current cough, fever, night sweats and weight loss. And if all these symptoms or any of these symptoms is present, then, or if any of these symptoms is not present, then the chances of not having tuberculosis is almost 99%. So it is rule out phenomenon and not rule in. That is what is called as negative predictive value. That is probability of not having disease if the test is negative. This is our test. We are testing for these symptoms. If these symptoms are not there, that is not, if these symptoms are negative, then probability of not having disease is almost 98 to 99%. If you add X-rays to this, if you add other things to this, then again this sensitivity will increase more. That means there is no current cough, there is no fever, there is no night sweat, no weight loss, and X-ray is normal, then chances of not having TB disease might be 99%. So in such proportion, this negative predictive value increases. So these are the TB screening signs and symptoms, and these are in children we just replace weight loss with poor weight gain and night sweats with contact with TB case. Because in children weight loss cannot be demonstrated again, but if there is poor weight gain, that is considered as one of the screening or TB symptom. So in any of these scenario, if there is any 4S positivity, if any symptom is positive, we label this case as 4S positive. We investigate for TB, and if there is TB, then we start with TB treatment. If there is no TB, we follow up and consider for IPT. I'll come back to IPT again. If there are other diagnoses that need to be considered, and appropriate treatment is considered, and IPT is started. If there is no symptom from these four, then assess the contraindication to IPT, and if there is no contraindication to IPT, IPT is started. That is prophylactic therapy for TB. We'll discuss that. Same thing happens in children. Children above 12 months of age. In children below 12 months of age, this algorithm is not followed. There very specific signs and symptoms of TB are observed, and diagnosis is made based on that. Why we moved from to new anti-TB treatment protocol? Because of problem with relapses. With alternate day treatment, though the treatment was good and patients were labeled as cured after completion of 6 months of anti-TB treatment, but the chances of relapse were very higher, and that is the reason we started now with daily anti-TB treatment. India is contributing to almost 50% of global relapse cases, which is very high, and also higher pre-treatment INH resistance in new smear positive cases, which also contribute to the higher treatment failure rates and increased emergence of rifampicin resistant mutants. So efficacy of TB treatment can be dependent on multiple things, in which one thing we can aim at is successful early outcome, successful long-term outcome, and newly formulated anti-TB medications. Early outcomes which can tell us about efficacy of anti-TB regimen is sputum conversion rate, that is from positive sputum to negative sputum, and then high treatment success, that is rate of cases defined as cured after completion of TB treatment. Long-term outcomes can be, it should not with this treatment regimen there should be less and less relapse cases, and also there should be less emergence of drug resistance. So the new formulated regimen, which is daily anti-TB treatment with 3 drug continuation phase, will be effective, and it achieves this desired results. So standards of TB care were revised, and there are 26 standards which were developed by the National Working Group during the national workshop, out of which standard 7 is for treatment, in which the new changes, I'll just read them out. In continuation phase, we are giving INH, rifampicin, ethambutol. Drug doses are given as per body weight. Unlike earlier, we used to give less than 30, more than 30, but now there are weight bands. Instead of intermittent, now daily dosing is given. Instead of separate pills, now fixed dose combination of drug is given. So this brings us to for new cases, the treatment is 2 months of INH, rifampicin, ethambutol, and paracetamol every day, and 4 months of INH, rifampicin, and ethambutol. This is the addition. And similarly, for previously treated case, that is category 2, 2 months of INH, rifampicin, ethambutol, including injection streptomycin. Then after that, 1 month of INH, rifampicin, paracetamol, and ethambutol. And similarly, like before, 5 months of INH, rifampicin, ethambutol. This is all given every day. I'll not go through these specific ATT situations. I think you have seen these before, and you can read them out also later. In new cases, total doses will be 56 doses or 8 weeks. In continuation phase, it will be like for TBs, 1 month is again considered as 4 weeks or 28 days, because the treatment pouches we give is for 1 week, is weekly or pouches. Those will be sufficient for the whole month. So number of pouches we give is like that. In one thing, it is not weekly. Actually, it is for 28 tablets will be present in one sachet, or sorry, one packet. So it is like adult doses are different from pediatric doses. It is not the same even if you see per milligram per kg doses. So fixed dose combination, it has various advantages. As we all know, it is simple and can easily acceptable, and procurement is easier, supply chain is easier, and also management is more effective with this. So if you can see here, the drug doses, these are low. That is why a person will have to take, based on their weight band, at least 2, 3, 4 or 5 tablets per day of fixed dose combination. So this is for in continuation phase. Previous one was for intensive phase, and these are the weight bands, like 25 to 39, 40 to 54, 55 to 69, and more than 70. And this is in intensive phase and continuation phase. And injection streptomycin is given, like first two weight bands, it is 500, 750, and after that it is 1000 and 1000. That is 1 gram. Dosing will remain same even if weight band changes during the entire course of treatment. So when you start with whatever the dose is, in the same dose you will continue the whole treatment. Dispensation, it happens like this, as all of you are aware that I'm not going in details of this. This is the first one step, second step and third step, and this patient is under weight band 2. That is why this patient will be receiving 3 tablets per day, and this continues like this. These are anti-TB drugs, or list of anti-TB drugs which you can refer to. For MDR-TB, treatment will be longer, that is 6 to 9 months intensive phase, which includes injectable kanamycin, levofloxacin, that is fluoroconazole, and then fluoroquinolone, and the ethionomide, cycloserine, and paracetamide ethambutol is also part of this intensive phase. In continuation phase, we give levofloxacin, ethionomide, ethambutol, and cycloserine. There are other reserve drugs like PAS and capreomycin, moxifloxacin, and others. In XDR-TB, again capreomycin, PAS, moxiflox, those are reserve drugs which are used. High dose INH is used. Clofazimine and linezolid. Linezolid is my new macrolide. It's not new now, but it's a macrolide. After oxythromycin, we use now linezolid, or azithromycin. Now we use linezolid is available. Amoxiclav is used as a, again, reserve drug. In fact, in some of the cases, cotrimoxazole also, high dose cotrimoxazole also is helpful, as some of the studies have shown. They also have anti-TB activity. So this is not discussed in. I've not seen much in people talking about this drug, but if you can see some of the research papers, they are in favor of that drug also, which is these days not being included as anti-TB drug, but it is again helpful. I'm not going through drug-drug interaction and adverse reaction of anti-TB drugs. You can again, I think, refer to this chart. But there are common drug interaction and anti-TB and adverse reaction of anti-TB drugs we should be aware of. Now there are two again commonly used anti-TB, 3 in fact, NH rifampicin and paracetamide, which can be hepatotoxic, and this is again not very uncommon, especially when we are using along with the other anti-TB other drugs like fluconazole and even in fact ART. For MDR and XDR, then refer to RNTCP. Yes, we are not treating MDR XDR at ART center. Whenever you find rifampicin resistance based on your CBNAT report, you need to refer that patient to RNTCP. That patient will not be treated for tuberculosis at ART center. That is clear. So if you see jaundice, also these patients will require individual drugs, for which you will have to refer these patients to RNTCP. You will not be able to manage them with fixed dose combination, because these patients will go on hepatosaline